Hi, my name is Kristen Shekel. I'm a physician assistant and co-founder of the Society of Veteran Disability Examiner PAs. Today, I will be doing the first of a three-part series on interpreting pulmonary function test. I do not have any disclosures, and this presentation reflects my opinions and not that of the Department of Defense, Department of Veterans Affairs, Veterans Benefits Administration, or my employer. Every effort was made to make this presentation evidence-based. That being said, the information today is meant to serve for informational purposes and not as medical advice. The learning objectives we'll be covering in this series are first, interpreting pulmonary function tests according to current guidelines, and then relating those results from the pulmonary function test to the veteran's claimed respiratory conditions. The clinical importance of this is that veterans have a higher prevalence of lower respiratory tract disease compared to the civilian population. Multiple factors contribute to this, including tobacco and nicotine use habits, deployments, and military occupation. Tobacco use is 15% higher in active duty military personnel and 8% higher in retirees compared to civilians. COPD has a 14.2 prevalence in veterans compared to 11.1 prevalence in non-veterans. And out of all the branches of the military, the Army has the highest smoking rates. Also consider use of tobacco, nicotine, chewing tobacco, and e-cigarettes. Another important caveat is that many veterans deploy. Deployments to Vietnam, Afghanistan, Iraq, and other parts of the Southwest Asia theater involve exposures to airborne hazards. Some of these airborne hazards are fine particulate matter, dust, burn pits, exhaust, fumes, blasts, industrial sites that may or may not contain asbestos, oil well fires, and herbicides. Think Agent Orange from Vietnam. Among veterans who deploy, 50% report dyspnea, difficulty breathing, 35% report exercise intolerance, and 30% report cough. Those statistics are from the VA Airborne Hazards and Open Burn Pit Registry, which has been collecting data about deployment history, exposure concerns, and symptoms since 2014. This is a reference guide that we have developed at SOVDEPA about conditions that are presumed to be caused by military service under the PACT Act. The PACT Act is the largest expansion in VA benefits since the inception of the VA. It was passed in August 2022, and it includes conditions that are presumed to be caused by military service. The only requirement is that the veteran had to have served in the location during the specific times specified under the PACT Act. So for burn pits or Gulf War exposures, for example, those apply to veterans who deployed to the Southwest Asia theater anytime after 9/11, also in Desert Shield, Desert Storm, so anytime after the 1990s as well for those conflicts. Agent Orange, those requirements are deployment to Vietnam or Vietnam era. There was exposures to Agent Orange stateside. Agent Orange was stored not only in the United States, but also in Canada and other locations in Europe. Camp Lejeune was a Marine Corps base in North Carolina and had contaminated water. Asbestos exposure could have occurred at any time. It really depends also on military occupation. And radiation exposure as well depends on military occupation for that exposure. But you can see for these different conditions that are presumed to be caused by military service under the PACT Act, just how many respiratory conditions are part of that. And again, the Veterans Benefits Administration does not so much concerned as if the veteran smoked, any lifestyle, family history factors. Again, if the veteran is determined to have served in an area location with burn pits or in the Gulf War, Agent Orange, Camp Lejeune, asbestos, or radiation exposures during their service, and they have one of these conditions that we have highlighted here, then they are granted benefits. So we have an entire, more comprehensive list of these conditions on our website, www.sovdepa.com. And you can definitely take a look. This is a free resource that we update frequently. And the conditions are found on the VA website and also in the Code of Federal Regulations website. So pulmonary function tests. These are the basics here we're going to go over in this first segment. The indication of pulmonary function tests can be for many different reasons. Most commonly, it's used to evaluate different symptoms that a patient is having, or maybe abnormal lab results that show elevations in hematocrit and hemoglobin, and perhaps they've had a sleep study that's normal, and you're just trying to look for, why is their body making more hemoglobin, hematocrit? Are they having some issue with air exchange in their lungs? It can be used as a screening tool, especially in veterans who are exposed to different aerosolized chemicals such as CARC paint, asbestos. It can be used to screen for occupational health monitoring programs. It can also be used to monitor different respiratory diseases and progressions such as COPD progression. We talked about the respiratory surveillance programs that exist in many occupational health settings. Research trials, clinical trials, epidemiological surveys. And then for what we do as veteran disability examiner PAs, pulmonary function tests are used to assess individuals for legal reasons. So compensation and pension exam is a legal exam that the veteran is undergoing for compensation pension benefits related to their military service. These are the different contraindications for pulmonary function testing. And, I won't go one by one through this, but main highlights to think about are severe hypertension. So blood pressure, that's greater than 160/90. Probably not a good idea to do pulmonary function testing that day until the blood pressure comes down, because it involves a forced expiration, which could, exacerbate that hypertension, put somebody into hypertensive urgency potentially. Also recent surgeries, again, not a good idea to do forceful expiration inhalations for those conditions if you've had surgery and stitches that are still healing, recent concussion, any sinus or infection, ear infection, collapsed lung, or an infectious disease such as like tuberculosis. You wouldn't want to do a pulmonary function test. And so if a veteran does have a contraindication to pulmonary function testing, you would simply write down the specific contraindication in the disability benefit questionnaire. And we'll go through that. I'll have the questionnaire in the next segment up, and I'll show you where you would write that. So there are many different types of pulmonary function tests, but for the Veterans Benefit Administration Respiratory Disability Benefit Questionnaire, DBQ, it only requires an FVC, percent predicted, FEV1 percent predicted, and FEV1 to FVC percentage. We're going to go through those, but please pay attention to percent predicted versus percentage. Pulse oximetry testing is something that you can easily do in the office as well. Also listening to the lungs with your stethoscope, looking at respirations. Are they labored? Are they shallow? Is there frequent coughing during the exam? Things like that. So this is really a good schematic looking at the subdivisions of lung volume. And so this shows subdivisions of lung volume as recorded by spirometry. Volume is depicted on the vertical axis. Okay, so this is how much inspiratory volume of the lungs that this person has, and this is how much they can exhale or expire. And then time is the horizontal axis. And capacity, you'll see vital capacity, that is a term that refers to a subdivision composed of two or more lung volumes. So again, this is an inspiratory capacity. It's composed of both the inspiratory reserve volume and the tidal volume, and the expiratory reserve volume, and the residual volume is the forced residual capacity. So any capacity is 2 or more volumes. This residual volume, that's all it is. It's just one segment. It's a volume. Total lung capacity includes all of this. So you'll most commonly see vital capacity, which is the inspiratory reserve volume, tidal volume, and expiratory reserve volume. But again, what we're doing for these veteran benefit exams is not full lung volumes or capacities. All we are doing is a forced expiratory maneuver. This is a Netter image showing the patient inspiring as deep as they can to their total lung capacity, and then exhaling as rapid and forcefully and completely as possible. And we get a volume time curve. So again, lung volume is the vertical axis and the horizontal axis is time. And so you'll see the forced vital capacity, this level here, is the maximum amount of gas that can be expired when the patient exhales as forcefully and rapidly as possible. If we go back to this image, you'll see this vital capacity. This is sometimes referred to as a slow vital capacity compared to the forced vital capacity. But again, this is what we are doing with the in-office spirometry for the Veterans Benefit Administration. And you'll see the FEV1, forced expiratory volume in 1 second. That's the volume of gas that's expired over the first second of the FBC maneuver. And here's just the tidal volume, them just breathing. They take a breath in, there's a negative deflection. They exhale, there's a positive deflection. So that's what we're looking at. That's what the volume time curve is. This is a flow volume loop. So the flow volume loop graphs the flow generated during the forced vital capacity maneuver against the volume. So again, this is the flow here, the vertical axis, and this is the volume. It's a little bit different than the volume time curve, right? Because the volume's here on the vertical axis and the time is on the horizontal axis. So this is flow to volume. And so this is recorded from the forced vital capacity maneuver. And, you know, it's called a loop when you have both the inspiratory curve, maximal inspiratory flow volume curve, and when you have the maximum expiratory flow volume curve. Then it's called a loop. But what we get from our in-office spirometer more commonly is just the expiratory flow volume curve. At least in my office, we don't get the deep inhalation part of it. So we just get a maximum expiratory flow volume curve. That's the technical way of referring to this, but it could be also called just expiratory flow volume curve. You'll see here the peak expiratory flow. You'll see the forced expiratory flow at any point during the forced vital capacity maneuver. And this is at 50%. And then this line here is supposed to, at this point, represent residual volume, the point at which no more expiratory air can, no more air can be expired. So this is a little bit different again than the volume time curve, but both equally important to looking at when interpreting and understanding these different loops are different in different conditions such as COPD, asthma. They will look different. So having this basic understanding builds a foundation here. This is an example test And for this, we want to focus on, reading through these different 6 areas. So the patient information, really important to get the height, weight, date of birth correctly, because the predicted reference values, the reference ranges used to compare what the patient's scores are to the reference, it all depends on the height, weight, and age of the patient being entered incorrectly. In this example, the predicted range is utilizing the National Health and Nutrition Examination Survey, NH3. There's also some systems that use Knudsen predicted values. I myself have made a mistake, of the medical systems going quick, and the height or weight or the date of birth is entered incorrectly. It really throws off the entire reference range, which then throws off the results. So always start. This is a pro tip. Always start by just verifying with the patient, double check, triple checking that their height, weight, and date of birth are entered correctly. The second thing is this flow volume. Again, it's a curve. And it's the expiratory part of the curve, not the inspiratory part of the curve. Again, expiratory, inspiratory. So that's the second thing. And these dotted lines are the lower limit of normal and the upper limit of normal. This is the volume time curve right here. And again, you'll see the reference range for lower limit of normal, upper limit of normal. You want to make sure the machine is calibrated. You have your results here, which will go into detail, and any test comments. Like in this one, it said it was performed standing and good effort. And each pulmonary function test may look different depending on the software used. So this is one example of a report that you'll get. And again, we're just focusing for these exams on the FVC, FEV1, and FEV1 to FVC. So you'll see here the predicted ranges. And again, that's based on the patient's height, weight, and age. You'll see their numbers, their actual numbers for trial number 1, 2, and 3. And that's without bronchodilator. Pre-bronchodilator means they haven't been given any bronchodilator. For the FVC and the FEV1, the numbers we record on the worksheet are the percent predicted. Okay. And you take the best one. You could also take an average as well. Many reports will average it out or give you the best one. Again, FEV1, you take the percent predicted. For the FEV1 to FVC, you do the actual percentage. Okay, not the percent predicted for the report, what you enter into the report. This is the biggest mistake that people make. They enter in the percent predicted for the FVC and FEV1, and then they mistakenly enter in the percent predicted for the ratio of FEV1 to FVC when the Veterans Benefit Administration requires just the actual percentage. This is another example of different type of software. So for this one, they have what the predicted would be for this person's height, weight, and age. They have the lower limit of normal. And then they have the best FVC value that was conducted. And that's from these 3 trials here. Trial 1, 2, 3. This is the best one. And so okay, this is 100%. 3.38 is what this patient's best FVC was. And the predicted is 3.4. So they just rounded to 100% predicted. FEV1, lower limit of normal 1.88, predicted 2.62. And then these are the results from the patient's 3 trials. So the best one was 2.7. That exceeds the predicted. So that's how they get 103% predicted. For the FEV1 to FVC ratio, okay, you'll see this would be the predicted value. This is the lower limit of normal. These are the patient's 3 results. So the best result is this one right here. This is the highest number. So that's how they have this result in the best category. But what we enter in the report is not the percent predicted, okay? I mean, this is 102% of what would be predicted for the patient's height, weight, and age, but we enter in the actual number. And you could do 79.7%. You just multiply by 100 to get that decimal to a percentage. Or you could round to 80%, either way. Post-bronchodilator testing needs to be performed if any one of these FVC, FEV1, or FEV1 to FVC ratios is less than 80%. So so again, that says different too. All these percent predicted, that's what you look at if you need to do bronchodilator testing. So none of these are less than 80%. Here we go, percent predicted, none of these are less than 80%, okay? But again, FEV1 to FVC ratio, what you put in the report is the actual percentage. So it can get a little tricky, but for the bronchodilator testing, you look at the percent predicted. If any of the percent predicted for the FVC, FEV1, or the ratio is less than 80%, you do proceed with bronchodilator testing. So validating the results. Again, like I said, the age, gender, height need to be correctly entered. Some machines include ethnicity, some don't. The NHANES3 or Knudsen 83 are the reference values. So it's just crucial that you enter in the patient's information correctly. And the variability is important to look at. So we're going to go into that now. So this is a great example of an acceptable flow volume curve. You'll see there's not a lot of artifact versus this one is invalid. There was either a cough or a variable effort right in the middle of it, okay? So that would be invalid. This is an acceptable volume time curve. There's more than 6 seconds of forcefully exhaling. That's exactly what you need to see. If it's less than 6 seconds, or if the 3 attempts, the 3 tries that the veteran does are just so, they're not consistent, there's too much variability to interpret that. What you look for on a report, and this is an actual copy of a report I got from a veteran. Again, all identifying information has been removed for privacy purposes, but you'll look at the session quality here. So this person got a pre-bronchodilator test, so no bronchodilator was administered, and then post-broncho testing was performed with albuterol. And you'll see the pre had very low variability. Anything less than 0.2 liters is considered low variability. So FEV1 had only 0.07 liter variability, FVC variability was 0.06 liters. A little bit more variability on the post-test could be due to fatigue, but it's still well below that 0.20 liter variability. For this example, the reason why a post-test was done, because this FVC percent predicted was just a little bit on the cusp at 80%, so I didn't want to chance it. So that's why I did a bronchodilator. And then again, for what I put in the report, FVC, I put at 80% pre-bronchodilator, post-bronchodilator, 83%. So it went up 2%. FEV1, pre-bronchodilator, I put 81% predicted. FEV1 post-bronchodilator was 88% predicted. And then FEV1 to FVC, I put 77.6% pre-bronchodilator, and then post-bronchodilator, 81.7%. Okay, so that's how I would complete the report with these values. And you can always look at what the best is yourself, but the computer is usually pretty accurate at taking the 3 trials and getting the best number. This is that same report and showing you again, just graphically, the full flow volume curve and the volume time curve, and how, there's a lot of reproducibility. These measurements are all very close together. There's not a lot of variability. And there is 6 seconds of expiratory flow. So this is, a good test, a reliable test. Any session quality that is A or B is considered a good session quality, a reliable test. So if it's C, then it's considered unreliable. D, F, unreliable. And then this is just a graphical prediction of that lower limit of normal and predicted values, and where the individual values for these tests fall in those range. And again, this is lower limit of normal, the dashed line, and then the upper limit of normal. So we'll stop there, and this will conclude the first segment. Thank you.